I'm Andrew Einstein, a cardiologist at Columbia University Medical Center in New York, and it's my pleasure to welcome you to Molecular Imaging Highlights from the American Heart Association Scientific Sessions in Orlando, Florida. The American Heart Association Scientific Sessions is one of the world's leading cardiovascular meetings. There are about 25,000 people here to share the latest news and advancements in cardiovascular medicine. And we're talking about some of the latest advances in cardiology medicine, and in particular, focusing on molecular imaging and molecular medicine. Gary, thanks so much for joining us today.
You're very welcome. It's a pleasure to be here.
We're here at Molecular Imaging Highlights at the American Heart Association Scientific Sessions in Orlando, Florida. So let's begin by asking a very fundamental question. That is, what is molecular imaging?
Molecular imaging is a branch of medicine that helps to identify various disease states. It's used primarily in cardiology and in oncology. In oncology, it's helped to identify the presence or absence of metastasis. In cardiology, there's a wide range of applications, particularly to identify patients with coronary artery disease, and specifically those who have more advanced disease.
Can you explain what myocardial perfusion imaging is?
Myocardial perfusion imaging is a branch of molecular imaging in which we use tracers to identify whether or not a patient has blockages in their coronary arteries. The way this is done is to evaluate the patient's condition at rest. So we inject a small amount of a radioactive tracer at rest, take some images using a sophisticated camera system, and then repeat this during peak stress. Stress is either in the form of exercise or chemical stress, in which a second tracer is injected and compared to the first. If there's a difference between those two, that indicates that a patient has a blockage in one or more of their coronary arteries.
Different types of cameras are used for molecular imaging and myocardial perfusion imaging in particular. Can you explain what types of cameras are out there and what the difference is between these?
In the world of molecular imaging, there are two types of cameras. One is called a SPECT camera, and the second is a PET camera. These are terms for the type of tracers that are used. A SPECT camera is perhaps a little older technology, very successfully done. We perhaps do 5 million SPECT studies a year in patients with known or suspected coronary disease. A PET camera is a perhaps newer technology that uses different tracers, and some people think increases the diagnostic accuracy of the procedure.
Now, what drugs are currently available for taking pictures of the heart in PET myocardial perfusion imaging?
There are two primary drugs. One is rubidium, which has a very short half-life, which means that one has to image the patient very quickly after injection. The second is ammonia, which also has a very short half-life, and images are also obtained very quickly. Both of these agents, because of the short half-life, are more beneficial to chemical stress rather than exercise stress.
Here at the American Heart Association Scientific Sessions meeting in Orlando, you and your colleagues presented results about a new agent. Can you talk about that a little bit? What is the agent and what's unique about it?
Yes, the agent is called fluoroperidaz. This is also a PET agent, but in contrast to the two that are clinically available right now, the half-life is 2 hours. So what this means is it gives us a little more flexibility in choosing either exercise or chemical stress as a way of identifying coronary artery disease in patients. We also think the image quality is better because of the characteristics of the tracer itself. So this is actually the first presentation of an F-18 agent in the clinical world. The study that we reported is what's called a phase 3 FDA trial. In other words, this was a trial that was approved by the Food and Drug Administration for evaluation of the product to eventually take it to the marketplace for clinical use.
Now, how do we characterize the accuracy of a new diagnostic test, for example, fluoroperidaz PET scans?
Well, there are many ways of doing it. The standard is to compare it to something we know very well, and that is coronary angiography. As you probably know, With angiography, a patient undergoes what's called cardiac catheterization, and a small tube is inserted into the arteries of the heart. So it's very accurate in determining the presence or absence of coronary disease. So a new tracer agent oftentimes is compared to the known standard of angiography.
Now, why wouldn't you want to do angiography in every patient?
It's an invasive procedure. There are known complications to doing it. And so it's far better to be able to evaluate a patient non-invasively, in other words, in a testing laboratory in which you don't have to do any invasion.
Now, when we compare a new test, for example, fluoroperidase PET scans, to this established gold standard, cardiac catheterization, as you described, how can we quantify how accurate the new test is?
There are many ways of assessing a new product. One of the most common ways of doing it is how well it performs against a known standard of angiography. In other words, can you diagnose coronary disease with this agent? And that is sensitivity. And also, can you identify a patient who does not have the disease and that specificity? In this particular trial, we also looked at other secondary measures such as image quality, diagnostic certainty, and in fact measured the radiation exposure to patients.
And what did you and your colleagues find?
We found that the sensitivity, in other words, the ability to identify coronary disease, was about twofold higher in patients who had received the PET tracer than in the same patients who received the SPECT tracer. On the specificity side, in other words, the ability to exclude coronary disease, the findings were the same. So an improvement in sensitivity without a loss in specificity. This was highly significant on both sides.
What differences did you find between men and women in this study?
Well, the original trial, which was reported about 3 months ago, evaluated around 795 patients of both gender, male and female. The particular study that we reported on at this meeting was a subset analysis in women, which constituted around 250 patients. And what we found was that the sensitivity and specificity worked equally well in women as in men. I think this is a very encouraging news because oftentimes SPECT has limitations of identifying coronary disease in women. We found that not to be the case with PET perfusion imaging.
So for women, PET perfusion imaging might be a better test than SPECT, is that right?
Yeah, well, that's certainly what our data indicate. And the other encouraging news is that it came at a lower radiation exposure. Now, the SPECT studies that were done were not anything to be worried about. However, the goal of all molecular imaging is to get the best image quality possible at the lowest radiation exposure. And in this case, with the PET agent, the fluoroperidase, the radiation exposure was approximately half that in patients undergoing SPECT.
What are the clinical implications of your new study?
Well, there are several. One is we think the diagnostic accuracy, if this proves to be true in the second phase of the FDA trial, if the diagnostic accuracy is better, then it may have an impact clinically in patients and which tests that the referring physicians may prefer. Furthermore, because of the higher image quality and degree of confidence the physicians have, we think that patients will be less likely to undergo procedures that they may not need, such as coronary angiography, to adjudicate whether, for example, a SPECT study is truly positive or negative. In the PET data, fewer patients will undergo those sorts of procedures. If they do undergo a procedure, it will be because they need an intervention.
Gary, it sounds like it's a really important contribution which you and your colleagues have made, and I congratulate you about that, and we look forward to hearing more about your future research in this area.
Thank you, I appreciate it. We look forward to the next phase 3 trial that should be conducted very soon.